your question, um, I could log on to my UpToDate on here. Do you guys know UpToDate? Yeah, use it, get it. I'm on that thing like 10 billion times a day. It's awesome. It's really easy to look up. It has the most up-to-date research, driven literature, recommendations for everything, because it's impossible for everybody to know everything, and especially for us to be PAs, we're so generalized. Anyways, I've done residencies for 4 years, 5 years talking about cardiology, so it's helpful to think. Troponin is found in skeletal muscle, but the troponins that we test for are, so you have your troponin I and troponin T, which are found in skeletal muscle. What we test for, the actual designation is CTNI, so cardiac troponin I, and that is specific to the heart, and that's the troponin that I was talking about. So I'll just read you kind of what it says. The cardiac troponin I and T are cardiac regulatory proteins that control calcium-mediated interaction between actin and myosin. These proteins are products of specific genes and therefore have potential to be unique to the heart. Studies performed with cardiac troponin I have failed to find any cardiac troponin I outside of the heart in any stage of neonatal development. So the troponins that I'm talking about are specific to the heart, and that's why they're so useful. It's not just your general control troponins that we're thinking of. This one is cardiac troponin, so it's only in the heart, and that's kind of why I was harping on it so much, is because that's the only one of the cardiac biomarkers that is only found in the heart. But like I said, there are a lot of other reasons that can cause an elevation of troponins. So troponins are just released whenever you have your myocardial oxygen demands are not met with tissue perfusion. So there are, as you develop and learn different things in medicine here, there are a lot of other different reasons that can increase your myocardial oxygen demand and decrease the amount of blood that is going to them, and a few of them are sepsis, anaphylaxis, shock, hypertension, things like that. Okay, so now we've gone through an hour and 15 minutes of all the crap. Now here's the stuff that we're actually here to talk about in STEMI and unstable angina. Unstable angina that is present at rest, does not have any associated EKG change or elevation of troponin. So this is the difference between stable angina, unstable angina in STEMI. And with stable angina, you'll have symptoms on exertion, but then it's resolved and it goes away at rest. Unstable angina, you don't have to type all this stuff out, we're going to talk about it later. Unstable angina is chest pain at rest. So you're just sitting there and and your chest is hurting and you're taking a break, you're sitting down and nothing's making it better. But as far as end-all diagnostic changes, you're not having any EKG changes or elevations in troponin. In STEMI, non-ST elevation myocardial infarction, so it's angina at rest that does have ischemic changes on an EKG and or elevations of troponin. And those are so anytime you talk about in STEMI and unstable angina, these definitions are good, but as far as treatment, it's all going to be the same thing. In STEMI and unstable angina are ubiquitous terms as far as treatment. They're both treated basically the same way. Epidemiology, so 60 to 65% of NMOIs occur in patients 65 years or older. Elderly and women have more of an atypical presentation, so I think we all know in here that women are weird anyways, so this is just confirmatory, this is science. I didn't write this down, you can research this. The symptoms for elderly and women can be non-specific. So like I said, your typical heart attack in your elderly people or women come in, they're not going to be like, I feel like an elephant sitting on my chest, crushing substernal chest pain, blah, blah, blah. It's not going to be that. It's going to be more non-specific symptoms. nausea, vomiting, dizziness, abdominal pain, headache, neck pain, weakness. And it's kind of hard to tease all those things out sometimes, and that's why I'm just this huge proponent of EKGs. Everybody that comes in that you even think is having any chest pain, just get an EKG. It's so fast. Nurses hate it. Are there any nurses in here? Am I talking about that at all? Yeah. Nurses hate doing them all the time. They're like, you want an EKG on this 400-pound lady, you know, to lift up her boobs and put the things all underneath there? It's just annoying, you know, but you're like, yeah, I want one because that's one thing, it's done quick, and it's like, oh, that looks stone cold normal. See you later. For your low-risk people. But, you know, that's why, you know, women and the elderly, when they have these very non-specific symptoms, even abdominal pain and acid reflux and things like that can all be symptoms of GERD, or symptoms of ACS masking as GERD. So it's also important to know that elderly and women present differently, and you need to have a higher threshold for doing tests on. Signs and symptoms of ischemia and unstable angina, and signs and symptoms of STEMI. So basically, all your ischemic type chest pains are going to kind of be broken down. There's this, you know, cool little mnemonic here that I found, OPQRST. It talks about all the different signs and symptoms, ischemic pain, the onset, it's gradual onset, but can be sudden. So, you know, it's so hard to say. Nothing in medicine's ever 100%. Nothing's ever like, it's going to be gradual or it's going to be sudden, you know. Typically, it's more of a gradual type thing and slowly kind of culminates to worse. Provocation and palliation, so those are just, you know, $2 words for worse and better. So provocation, what makes it worse, and palliation, what makes it better. Pain is typically worse with activity. That's your chest pain on exertion and things like that. The more you tax the heart as far as increasing your myocardial oxygen demands, the more it's going to become ischemic and build up lactic acid, which is what you get your pain from. The lactic acid irritates the cardiac muscles. That's where you see your pain. Quality, so I mean, there's all sorts of different ways people are going to describe your chest pain: crushing, burning, tightness, squeezing, pressure, discomfort. You know, it's typically, not all the time, typically more of a all-around type thing and not just located to one spot. You know, typically people are like, oh, I'm having terrible chest pain right here. You know, they're not going to point with one finger. It's going to be like, it's all on my left side of my chest, or all on my right side of my chest, or all of my shoulders and neck and things like that. That's where we come into with radiation, shoulders, arms, necks, lower jaw. And you guys can kind of look up on your own about why you get these radiation type symptoms. It's actually kind of cool about the nerve tracts and things like that that go through your mediastinum and how the lactic acid activates those nerve tracts, and that's how you have jaw pain whenever you're having a heart attack. It's all about the nerve tracks that run down through here. But it's not necessarily important to know. But no, you can have radiation or symptoms. Site, like we talked about, is usually diffuse in nature and typically not in one spot. So it's, you know, you're going to say it's hurting all through here. And there's also, I don't know if I have it there, I just thought of it right now. There's some kind of sign, you'll have to look at it. It's called some dead person's name sign, where somebody's holding a clenched fist over the center of their chest, and they did some kind of research back then.
Yeah, Levine.
There you go, Levine sign, yes.
We have your handout pulled up, don't give us.
Oh, is it in there?
Yeah.
Oh, okay.
We knew that.
I should probably know what I typed out in my own handout, but yeah, Levine sign. So people like, you know, it's hurting right here. It's kind of one of those old dead person signs. You guys shouldn't have told me that.
I know. I could have seemed real smart for a second.
Congrats. And now you're back down to normal. Timing, this, you know, in the literature it says angina is usually brief, lasting 5 to 15 minutes, but it can be continuous and unrelenting, so it doesn't go away and can be longer. The longer you're having chest pain, to me, the longer you're having unstable angina, chest pain at rest, the the more you should cue into a worsening pathology within a specific time frame. And what do you think that time frame is?
91.
Say it louder.
91.
No. I just heard it.
12 hours.
Yeah, you said it. Oh, it's the girl I need to give a hard time to more. Yeah, I remember. 12 hours for me because of the troponins, right? You can, it's a really quick test. If it's greater than 12 hours, you get a negative troponin, boom, you're done. If you're having a true myocardial infarction from a thrombus that's blocking the coronary artery, if you're going greater than 12 hours, you're talking about, you're losing cardiac tissue every second for that whole time. When you're talking about 12 hours or more, you're talking about a large transmural, meaning the entire thickness of the myocardium is infarcted. You're gonna be sick. When you have an entire huge section of your heart that is dead and is not beating and not transmitting electrical impulse and things like that, you're gonna start going into cardiogenic shock, arrhythmias and things like that. Oh, that's for the next lecture. So over the 12 hours, people end up having chest pain for 5 years. I don't necessarily not worry about it, but I'm not talking about rushing into the cath lab within 90 minutes. Now, people can have chest pain for 2 or 3 days, and it's your job to kind of tease that information out of people, because it could be just on and off chest pain for 2 or 3 days, and then now all of a sudden, 90 minutes ago, it got worse. And that's a very important distinction that you need to get out of them and have them elucidate to you about that, because that on and off chest pain is stable angina that's caused from ischemia, and then now all of a sudden you're building yourself up into where that big white thrombus is now turned into a red thrombus, including that vessel, and that's when all of a sudden, it's been hurting on and off for the past week, and I've just been getting rid of it, but then now, 20 minutes ago, it stopped, and it has been increased in intensity. So timing is also important too. Again, this section is going to go by pretty quick because we already talked about all the laboratory and radiographic findings. Your CK, CKB, troponin, myoglobin, you're going to be your basic cardiac enzyme biomarkers that you're going to want to get, paying more specific attention to your troponins. Remember to plot the change of the delta of the troponins if the diagnosis is unclear. So the first time you get a negative troponin does not mean that you're not having a heart attack unless it's greater than 12 hours. We talked about the 90 to 120 minute acceptable time frame for repeat troponins in the emergency department as far as a rule out type plan. And those are the ones that I do, and a lot of people in my group and the ones that I trained with. I do for those people that I'm going to send home. Those are the people with the heart scores of 0 to 3 and the TIMI scores, of I would say 3 or under, that I'm going to send home. I'm not just going to get one troponin and send them home, even though we know that troponin should peak at 12 hours. Patients are stupid, and you have to understand that going into it. They're stupid, but they're not dumb because they mean to be. It's because people never can tell you exactly what's going on with them in an exactly perfect time frame for everything. It's so subjective between people, and so you can't trust people to say, like, oh, well, this started at exactly 8 a.m. and it's been going on. You're like, oh, well, that's 12 hours. So if you're going to send somebody home with chest pain, you better well damn make sure that they're not going to fall dead of a heart attack, or you're going to get your pants suit off. So anybody I send home, I always get a 90 to 120 minute troponin. Get that second one. We do ultrasensitive troponins here. I document 2 EKGs, 2 negative troponins, and a low heart risk stratification score as a justification for sending these people home. And remember, again, renal failure, sepsis, etc. will cause troponins can be falsely elevated, so not all troponin elevation is caused from acute coronary syndrome. But all troponin rise is from tissue damage to the heart but not all tissue damage to the heart is caused from ACS. All right, so treatment. So this is important here, and Mason told me that you guys are going to be having pharmacology in my stuff this afternoon, which is great because I'm not going into great detail on the pharmacology of everything. I'm giving you a brief purview of what we do, but if you're going to have a lecture from a pharmacologist, that's going to be the best thing for you about how all this stuff works and the exact dosages and timing that you need to do. But as far as a general treatment scheme, these are what you need to do. So your first kind of general treatment scheme is going to be anti-ischemic, and analgesic just means pain control. So you're anti-ischemic, so ischemia is lack of oxygen to whatever tissue. So the anti-that is getting more oxygen and blood flow to the tissue. So the first thing, one of the few things that we have is nitroglycerin, or what's the quote-unquote nitro. This medicine dilates the coronary arteries and systemic veins to increase myocardial blood flow. So it does this through a big, huge reaction that causes vasodilation, meaning the vessels get bigger. So you're talking about clot or thrombus or plaque that's occluding a vessel. That plaque, clot, thrombus is going to stay relatively the same size over that period of time. So if you dilate that vessel, you're going to get more blood flow around that ischemic clot. Nitroglycerin can be given in a bunch of different ways. It can be given as a paste, it can be given as sublingual, it can be given as intravenous. Your typical sublingual nitroglycerin, 1 every 5 minutes for the first 15 minutes. Anybody who has continuous, unrelenting chest pain who is not hypotensive or borderline hyponormotensive, you can give an intravenous drip of nitroglycerin. And that is also helpful in determining chest pain due to coronary type symptoms. If your chest pain resolves with nitro, then I think it's pretty safe to say that it's coming from the heart. But that doesn't necessarily mean that you have to send the catheter right away. All right, oxygen. So this is a big deal with me, and you know, who here has heard of Mona? Raise your hand. Only one. All right. Well, if any of you other guys hear the word Mona, I just want you to just be like, yeah, great, and then don't ever think about it again because it's all wrong. Mona means morphine, oxygen, nitrogen, or nitroaspirin. That's been what was taught to me, and that's still being what's peddled around to nurses, PAs, and hopefully not physicians. I think most people have gotten away from that. That's kind of what your general old school way of treating chest pain was, mnemonic: morphine, oxygen, nitro, aspirin. Well, they got nitro and aspirin right, but morphine and oxygen are wrong. They've done recent literature studies, and they found that you only need to give oxygen to people who are clinically hypoxic. So that's oxygen saturation, SpO2 of less than 92%, 92, 93. So research shows that supplemental oxygen is not beneficial and could be harmful. So you build up of free radicals from the oxygen, and free radicals, as we all know, worsen cellular death and hasten cellular death. So you're going to see it because it's the way it's been taught for thousands of years, and everybody gets morphine, oxygen, nitro, aspirin. So you're going to see your nurses in the emergency department, you're going to see everybody come in, if somebody comes in with chest pain, they're going to instantly slap oxygen on them because that's what they taught. And I tell them to take it off every single time unless they're hypoxic. If they're hypoxic, give them oxygen. If they're not, they don't need it. It doesn't help and can be harmful. And the next one is morphine. Morphine for analgesia is not used anymore. I stick to more fentanyl and Dilaudid for pain control. But if you want to sound really smart to your preceptors or anybody that says they want to give morphine and chest pain, talk about the Crusade initiative or the Crusade trial. That's obviously an acronym for something that I don't know. But recently, a couple years ago, they did the Crusade initiative or trial. They retroactively looked at tons of ACSs and MIs and everything like that, and they found that you had a 30% higher, it's actually like 29.8, but 30% higher adjusted mortality in patients that received morphine during ACS. So if you got morphine during your heart attack, 30% more of those people died when they got it. They don't know why, but they did. So don't give morphine, unless you want to kill someone. 30% of your people. But Mona is peddled around, and people, it's like ingrained in people. You're gonna have your preceptors that you go out that are gonna be peddling Mona. And, I don't necessarily would advocate arguing or disagreeing with your preceptors that much, but on this point, just be like, yeah, okay, and then just know that you don't want to do it. Or you can be like, man, I heard about this trial called Crusade something, maybe we should look at that. And then hopefully they'll realize that they shouldn't be doing it. And I think oxygen came from Crusade as well, but it may be a different trial that came from. But oxygen and morphine are out, nitro and aspirin are in. But we'll talk about aspirin as far as antithrombotic goes. The nitro is antihistaminic. All right, now antithrombotic. So you have anti-ischemic, which is trying to lessen increase the amount of oxygen to the tissue. Now antithrombotic, you're trying to decrease the amount of clot formation that you have. You can't, these medicines aren't going to lyse the clot, meaning break it up or dissolve it, but they're going to prevent its accumulation of more. And one of the first things we do here is aspirin. Aspirin is a core measure. It's regulated in research through Medicare and Medicaid, and you won't get paid and you will get dinged if you don't give aspirin. If you don't have a anaphylactic contraindication to aspirin, just give it. It's not going to hurt anybody. I mean, aspirin does increase your bleeding risk and everything like that, but you're not going to, unless you obviously don't want to give aspirin so you just, syncopized and may have a head bleed or something like that, that would be a contraindication. But just give aspirin to chest pain. It's easy. Even if you don't think it's real chest pain, you think this patient's just a crazy person, give them 324 aspirin. It's not going to hurt them, but it is a core measure. If you don't give it, you will be dinged against it. And a P2Y12 receptor blocker like Pascal, Tigrelor, and Clopidogrel. These are also antiplatelets, and they work by a little bit different mechanism, but your pharmacology professor is going to talk way more detail than you're ever going to know about these two things. So everybody gets aspirin. Just keep that in your mind. Everybody gets aspirin. Not everybody has to get nitro. Not everybody has to get Dilaudid or fentanyl, and not everybody has to get anticoagulation, but everybody gets aspirin. Another one, anticoagulation. So this one, the aspirin is an antiplatelet, so this inhibits platelet formation. Anticoagulation inhibits clotting factors, which you guys should know all about because you had blood stuff. Do you guys know about unfractionated heparin and low molecular weight heparin and the differences? Good. So, the big difference is just the half-lives and the way it's administered. The research, I don't know if they've said which one's better, quote unquote, but in practice, Lovenox is what's given more that I have seen. I mean, it's just a one-time sub-Q injection once a day or twice a day. You don't have to put them on a drip. You don't have to do serial PT, INRs, or which is it for heparin, PT or PTT? That measures heparin. I see, I hear so many P's. So raise your hand for PT with one T. Good. Raise your hand for PTT. Yeah, exactly. So the way I remember that is the two T's make an H. There, they line up, they make an H for heparin. Oh yeah, that blew somebody's mind after I heard it. So anyways, low molecular weight heparin, Lovenox is can be your best bet. But I do know some facilities and stuff that start people on heparin drips for ACS, and that's not wrong either. But I think it just kind of depends on your facility and what your cardiologist wants. Other treatments, you guys are going to talk way more in detail about this in pharmacology, but just in case you did it, I wanted to make sure it was in there. Beta blockers and statins should be initiated within 24 hours of admission. Beta blocker initiation with an acute MI is another core measure as well. And then ultimately, as far as treatment, PCI is going to be your best bet. That's going to identify the blocked arteries and revascularizes either with stenting or angioplasty or different things like that. Fibrinolytics, which we'll talk about here in a little bit, are not indicated in NSTEMI and unstable angina. So fibrinolytics or thrombolytics or basically clot lysis medications are not indicated, so don't give them. All right, now we go on to STEMI. Definition, ST elevation, myocardial infarction, we've already beat that horse so many times, we don't need to talk about any more symptoms. It's going to be the same, chest pain type, ischemic chest pain symptoms. Lab, again, refer to our cardiac biomarkers section. I'm sorry, does anybody have any questions over NSTEMI or unstable angina as far as treatment goes? And STEMI, here we go. Pharmacologic, it's the same as in STEMI. It's going to be your same anti-ischemic and antithrombotic with aspirin and nitro and anticoagulation heparin. Another one, so this PGY12 inhibitors, the ticagrelor, the clopidogrel, things like that. I've never had a cardiologist ever tell me to give them, and I've never really given them in an acute setting. As far as the emergency department, I've seen some people give them, but as far as where I trained and what I do now, I don't, and I've never had a cardiologist consult with Oklahoma Heart Hospital tell me to give them. But the literature does say that aspirin and these PGY12 inhibitors are generally accepted as what you give for an acute MI. I don't know if they go to the heart hospital and get those with the cardiologist there, whatever. But if you're going to give them in your emergency department, the selection of which PGY12 inhibitor is going to be determined on what your overall intervention strategy is. Whether or not you're going to do a PCI or fibrinolysis determines what specific PGY12 inhibitor you're going to get. So basically, just give clopidogrel if you're going to give them a dose of streptokinase or all right, choosing a reperfusion strategy. So these, in the city and stuff, when you have a STEMI, it's super easy. All the hospitals have, cardiology. Mercy's cardiology is just right across the street at the Oklahoma Heart Hospital. But it's not a big deal. Just call a cardiologist, take them to the cath lab, and you're done. These are the ones that you get whenever you're in, Stigler, Oklahoma, or Sayre, or, Bodido. I think there's actually a town called Bodido, Oklahoma. That you start to get a little bit nervous on because you got a STEMI, but you can't get them to, nobody get them to the cath lab within 90 minutes. So gold standard is cath lab in 90 minutes. That's going to be the answer for most everything unless you can't. It's preferred for patients of great old age, higher risk of bleeding, or anybody who has an absolute contraindication for fibrinolytics, and we'll kind of talk about that a little bit here. But if you don't have access or not in a hospital for a place you can do a PCI in 90 minutes, you then give fibrinolytics or thrombolytics. Those two names are ubiquitous and it'd be the same thing. We'll let your pharmacology people talk about fibrinolytics and how exactly they work. Basically, they just dissolve fibrin, which is the component one of the components that helps platelet aggregation forming clot. But the problem is that it dissolves it everywhere. It's not just in the heart. Every clot that you have everywhere in the body is going to be dissolved. So it's a very dangerous medicine and has very high risk, and you can kill people with it very easily. There's no medicine that you can turn it off. You can't just stop the infusion or stop the process. Once it's done, it's done. And I know I've seen patients that have had this strokes and things like that from getting thrombolytics from MIs. So use of PCI times greater than 90 minutes must be given within 30 minutes of the identification of STEMI. So you should know whatever place you're at, whether or not you have access to a PCI within 90 minutes. If you don't, you know that if somebody comes in with a STEMI, you're going to be giving thrombolytics within 30 minutes to revascularize the heart. And we must review the absolute contraindications for administering. I think they are they in my handout?
Yeah.
Yeah, okay, so we're not gonna go over them, but that's like a checklist thing. Obviously, history of intracranial hemorrhage in the brain, is more important than the heart. So the brain's obviously the most important thing, so you don't wanna do anything that's gonna damage that of the heart. All right, and we're gonna talk a little bit about Prinzmental variant. It's difficult to diagnose this. This isn't a clinical diagnosis. You actually have to be in a cath lab. Yes, ma'am.
What are you gonna do if they are contraindicated? Like if they have had a stroke or whatever?
And you don't have access to a PCI?
Yeah.
Then that sucks. Yeah, you're gonna do the levonorgestrel, and even then, that's
Yeah.
iffy on somebody who has a breathing risk or has a history of an ICH. I wouldn't give somebody levonorgestrel that has an absolute contraindication for arm legs without talking to a cardiologist. And then it's just gonna be getting them to a cardiologist as fast as possible. That's what Metaflight and helicopters and things like that are there for, getting them to the cath lab as soon as possible. But, that's one of those things that your hands are tied. You don't wanna cause, our general rule of term, do no harm. You don't wanna do more harm to the patient. What would normally be done would just get them to the PCI, so. Yeah, so, those suck, but there's nothing you can do about it. Any other questions on STEMI? All right, Prinzmental variant, vasospastic angina is characterized by episodes of angina at rest that promptly resolve with nitrates or just resolve on their own. Basically, it's just coronary artery vasospasm, so the artery clamps down and decreases blood flow to the heart muscle just by spasm of the artery muscle wall and not necessarily due to a clot. There's some diagnostic criteria to do it. It must be nitrate responsive. The EKG changes are transient. You can see ST elevation, but then they go away. And then you have angiographic evidence of coronary spasm. So when they're in there spraying that dye on the heart, they can see, the spasming of the vessels itself. You're probably never going to diagnose this in the emergency department or family care, urgent care, whatever. It's going to be diagnosed by a cardiologist because you have somebody that's having a ischemic type chest pain and EKG change, they take it to the cath lab and there are blockages, or there's no blockages, everything looks clear. Signs and symptoms typical for ischemic chest pain. They say most events happen in early morning hours while at rest. I don't know why that is. Chest pain typically resolves in 5 to 15 minutes. You can have EKG changes because you're going to have the same type biomarkers and EKG changes depending on length of time of the vasospasm as you are going to have with acute coronary syndrome because you're blocking blood flow to the heart, but in this instance you're blocking blood flow because your artery is spasming and not necessarily due to thrombus. Stress testing, most people have a normal non-invasive stress test. They'll have a normal cardiac stress test or treadmill stress test. Because if you don't catch it right at the vasospastic activity, you're not going to see it. Treatment, lifestyle modification, smoking is one of the main triggers for any arterial vasospasm. So you got to stop smoking, which they never do. They'll continue to smoke, but you just say whatever. First line treatments, calcium channel blockers. Second line is long-acting nitrates, but you can develop an intolerance. And others, MAG, statins, and rho kinase. You'll talk way more about calcium channel blockers and pharmacology about the use of vasospastic arterial disorders. Anytime you have a spasm or a problem with the artery, calcium channel blockers is going to be your answer. All right, yes?
Is there a reliable way to tell when it's Prinzmetal versus when it's an STEMI? Because otherwise, if they come in and get the EKG and it's elevated, so you just might give them like a bypass that they don't need or something?
Yeah, well, the bypass,
Or the
PCI.
PCI.
Yeah, well, that's how they're gonna diagnose it. Is because there's literally, you can't tell until you get in there and then squirt it with the dye and you'll see that their arteries are completely clear. That's, because, that's why I said you'll never diagnose Prinzmetal variant in an emergency department or an urgent care center, because there's no way you can know until you, because chest pain can resolve with nitrates in ACS, but that doesn't mean that it's, due to a clot or vasospasm. So the only way to truly know whether it's Prinzmetal variant is that you get them in the cath lab and you don't see any clots. Yeah, good question. But I mean, ultimately, the treatment's gonna be the same, but the antithrombotics and antithrombotics, things like that won't do them any good, but they're not necessarily gonna do them any harm. It'd be more harmful to say that this is Prinzmetal variant, and not get them anything that actually be ACS. But if somebody comes in and has a known diagnosis of Prinzmetal variant, then you can kind of play your cards with what medicine you give them and how you treat them. But I would still give them a dose of aspirin, but you're still going to do nitro as well too, because that's the acute care treatment of it. All right, any other questions? All right, stable angina, so this is just ischemic chest pain that occurs on exertion and resolves at rest. So this is going to be the majority of the people that you see. This is going to be the old people, the obese people, the people with a lot of hypertension, diabetes, and high triglycerides and things like that. I gotta come in, they walk 10 feet and they're out of breath and their chest hurts and they have to sit down. When they sit down, it all goes away. That's the kind of classic thing between unstable and stable angina. Lab and radiographic, so these are the ones that you would want to do stress testing and coronary angiography on. You're not necessarily going to take them straight to the cath lab or anything like that. Some cardiologists do, because that's how they get paid a lot of money, by taking people to the cath lab. You can also do stress testing to see what the cost for that chest pain is. As far as stable angina, acute and chronic treatments are a little different. Acute treatments, these are the type of people that are given nitroglycerin, sublingual, or tab sprays to go home with, and they take one tab, one spray every 5 minutes for 15 minutes until resolution of symptoms. If it doesn't resolve after that, then they say go to the emergency department. Chronic treatment is going to be baby aspirin, so it's an antiplatelet to keep thrombus formation. First line beta blocker, second line calcium channel blocker, and third line is long-acting nitrates. I'll let you guys talk more about that in pharmacology, about the treatment of ischemic heart disease. But that's kind of your typical breakdown for what all people need to be on. They also need to be on statins as well to decrease plaque formation. But again, I'm not going to sit and talk about pharmacology that much because we're not limited on time. Okay, any other questions about any ACS, NSTEMI, unstable angina, anything like that? Nope, we all good? Cool. Oh, we're gonna get done so early. Are you guys happy?
Yeah.
I mean, I'm kind of happy too. I was a little nervous talking for 4 hours. It actually got done pretty quickly. And this hypertension and cardiogenic hypotension lecture is definitely going to go by pretty quickly, because a lot of it is pharmacological management. In your hypertension pharmacology, did they talk about hypertensive crisis and hypertensive urgency? Yeah, the treatment's great. Okay, so I'm not going to go too much in depth about all of that stuff. But we'll kind of talk more about the signs and symptoms and recognition of that. Everything okay? Do we need to wait for him?
No, not for
That was cold-blooded, dude.
He's smart.
He doesn't need
He's
to.
a doctor, yeah.
Oh, is he really?
Yeah.
Oh, okay, so he's like, I don't need to listen to you. Sure.
We don't have to say that.
So definitions between hypertensive urgency and crisis, you guys may have already gone over this in pharmacology. So severe hypertension, systolic over 180, diastolic over 120. Hypertensive of urgency, so this is people who have severe hypertension but are asymptomatic. They're not having any signs and symptoms of end organ damage. That's the difference between hypertensive urgency and hypertensive crisis / emergency. So when I said hypertensive crisis, that's the same thing as hypertensive emergency. These are the people who have blood pressure in the severe range, but then are also symptomatic. They're showing signs and symptoms of end organ damage. So etiology, I mean, there are tons of different etiologies for hypertensive urgency and crisis. And sometimes the hypertension itself is more or less a symptom of another disease process and not necessarily due to just long-standing hypertension. It also can be just due to long-standing hypertension. There list a few things I have on here that people can present with hypertensive crisis urgency. People with AAAs, ischemic strokes, MIs, left ventricular failure, renal failure, eclampsia, sympathetic crisis, or toxidrome. Toxidrome is like ingestion of drugs, cocaine, methamphetamines, abrupt cessation of antihypertensives. So since you guys already had hypertension, what is one of the drugs that'll cause that? That if you're on it for a while and all of a sudden you stop it or miss a couple doses, all of a sudden your blood pressure is gonna. Beta blockers are one of them. I'm thinking of another one.
Clonidine.
Yes, yeah, clonidine. Clonidine, I see that a lot in the ER. People come in, blood pressure's in the 200s, and they're just like, well, I didn't have the money to get my clonidine, or I didn't take it for the past couple days because I've been vomiting so much, or so on and so forth. Clonidine, I know one of our hospitalists at Mercy hates clonidine because when people stop taking it, all of a sudden their blood pressure shoots through the roof, and sometimes it's hard to get it back down. Signs and symptoms, these are the ones that you're going to have to be on the look for. It's going to be easy to recognize a severe hypertension because it's part of the blood pressure measurements as part of your vital signs. You're obviously going to look at the vital signs because they're vital. I think we talked about that in our last lecture. Neurological, so most of them, in my experience, are neurological based symptoms with hypertensive crisis or urgency. These people, they're agitated, there's a whole spectrum from somebody who just has a little bit of a headache and maybe some blurry vision to people who are stuporous, in a coma, unresponsive, things like that. Those are all neurological symptoms associated with hypertension. Or cardiopulmonary, you can have shortness of breath, chest pain, dyspnea, tachycardia, back pain. Those would be kind of more along the lines of your hypertensive crisis being a symptom of something else, like a AAA or an MI or things like that. Ophthalmological papilledema, you guys heard of that yet? Yeah. So blurring of the optic disc and cup. Now ask me how many times I've seen that in my entire life. Yeah, 0. And if anybody says, anybody that didn't dilate somebody's eye in an office and turned out all the lights and then used like a very awesome looking ophthalmoscope that cost $1 million and said they saw it, they're lying too. You can convince yourself that you think you saw it. But you still want to look for it. I'm not going to tell you not to. No, I don't. You still want to do a good retinal exam and looking for the papilledema, because that is definitely a sign of increased intracranial pressure, which can be associated with a hemorrhagic stroke and or hypertension crisis or urgency. It's always good to document that there was no papilledema. But in practice, I don't see too many people actually finding it because the ophthalmoscopes, one, you have emergency departments suck, and two, it's difficult to really, it's honestly very difficult, all kidding aside, it's very difficult to see it without dilating somebody's eyes. When you use some drops, like Myotronics or something like that, to dilate somebody's eyes, it's a little bit easier to see. But we as PAs can't use drops that dilate people's eyes. That's on that list of prescriptions that we can't give. All right, so your lab and radiographic findings, I mean, there's not gonna be, like I said, this is more or less a clinical diagnosis. You don't necessarily need your labs or radiology to diagnose somebody with a hypertensive crisis urgency, because basically it's just an elevated blood pressure with signs and symptoms of end organ damage. So, the determination between urgency and crisis is what labs are helpful in doing it, but just overall, if somebody's having dizziness, headache, nausea, vomiting, their blood pressure in the 200s, you don't need that to say exactly what's going on, but they're helpful in looking for other causes and or in organ damage. There are a lot of different lab tests that you can run. These ones I just put up there because I think they're the ones most important. Your basic metabolic profile or your analysis looking for renal function, so your kidneys are going to be one of the things that are responsive to changes in blood pressure most, because kidneys help regulate blood pressure to a great extent, but they're also going to be very responsive to changes in blood pressure. Elevations in BU and creatinine can be a cause for poor perfusion or damage to the kidneys. Red blood cell counts can indicate acute tubular necrosis. You guys can talk about that later, neurology. And cardiac biomarkers, again, looking for elevations in troponins. You can have the troponins be elevated, but it's not from acute coronary syndrome. It could be from hypertensive crisis. But you're looking for quantifiable data points that can show you end organ damage, and the organs that we can that we have labs that we can measure quantifiably are the kidneys and heart that we can measure function on. A lot of other labs that we do, but there's a few of them that we can get that actually measures the actual function of the organ itself. Lab, radiology, so chest x-ray, not going to really help you a whole lot unless you're looking for a wide mediastinum for aortic dissection, things like that. CT, in my mind, the way I was trained, I don't know, I was trying to look for literature that supports it. What I found wasn't something that says you have to do this. But if you're having hypertensive crisis or hypertensive urgency with neurological symptoms, you need, standard of care I would think would need to be a CT, non-contrast CT of the brain. Because a lot of those people that are having neurological symptoms could be having a hemorrhagic stroke. Their blood pressure got so high that it ruptured a saccular aneurysm in their brain, and now they're having a hemorrhagic stroke, and that's what's causing that. And that would be something that you would need to decrease the blood pressure sooner, more rapidly than usual, and would also need neurosurgical intervention, things like that. CT, the chest, abdomen, pelvis can also help you evaluate aortic dissections or pulmonary embolisms or things like that. That can, other causes to hypertensive crisis urgency that's not necessarily just due to long-standing hypertension. This is what a CT would look like, somebody who's having a hemorrhagic stroke. So obviously your normal looking brain, your sulcine gyri, things like that, as your ventricles here, frontal or maxillary sinuses. This one is, obviously anybody can see that that's not looking great. Blood comes up as white on a CT scan because it's very dense. This big collection of blood, this would be intracerebral hemorrhage. That would be something you want to see in a patient like this. And chest x-ray, so this would be the wide mediastinum. I'm sure you guys have talked all about that, correct? Mm-hmm. Chest radiology, good. And here is a non-contrast or a contrast CT. You have to have contrast on a chest CT to look for an aneurysm. You have to have contrast media going through the vessels to see the dilation. So this is this right here, I believe, is the aneurysm, the big outpouching, and this is the dissection that you're looking at. This is blood between the two layers of the artery. So the difference between an aneurysm and dissection. I'm sure you guys have lectures over aortic dissection in this class too. Okay, so treatment for asymptomatic hypertension. So hypertensive urgency, they have severe blood pressure, but they are asymptomatic and everything looks good. Target goals for hypertensive crisis and urgency would be a blood pressure under 160, systolic under 160, and a diastolic under 100. That's what the textbooks say. I've sent people home with systolics in the 200s before, and I do it all the time, and my colleagues do it all the time. People have high blood pressure, and just because you have high blood pressure, even systolics in the 200s, doesn't mean that you need to be admitted to the hospital or anything like that. If you're asymptomatic and all your labs come back stone cold normal, and you have documented blood pressures in your chart of at or around that number, it's perfectly acceptable to give these people PO medicine and send them home and have them follow up with their primary care doctor in the next day or two. You'd want to have adequate follow-up. You just don't want to kick them out and say, see you later. But, people have long-standing hypertension, and high blood pressure in itself it's not an acute problem if you're asymptomatic. You're not going to fall over dead or have a big aneurysm or anything like that if you're not having any problems with it. Eventually down the road, you're going to have renal failure and eye problems and peripheral vascular disease and all sorts of stuff. But as far as acute setting in the emergency department, it's not necessarily anything you're super worried about. But 200, I'm not saying that that's done all the time. My cutoff for me personally in my practice is about 180. If I can get your blood pressure under 180 or around 160 for your systolic, that's about what I'm comfortable with sending you home. And then under 100 for your diastolic. Have you guys heard of MAP, mean arterial pressure? I'm familiar with that, good. So it should be lowered more than 25 to 30% over a relatively short period of time. So you don't want to take somebody who has blood pressures in the 230s over 120s and then give them a shit ton of medications and then drop them down to 120 over 80. That will send them into organ damage because all their organs over time have become accustomed to that type of blood pressure to function normally. They've adapted to that type of perfusion pressure. So dropping that perfusion pressure, even though we're dropping it to a quote-unquote normal pressure, can cause them to go into problems. So you don't want to drop people too quickly, too fast. Asymptomatic hypertension, I usually do oral medication. I do oral Clonidine. It's faster acting and it has a little bit of a longer half-life and is good. You can also do oral nitrates or oral amphetamine, a calcium channel blocker. So kind of the difference between that and giving IV medications would be the asymptomatic type stuff. Yes, sir.
Are you sending them home on a script for that, or are you treating just a single episode?
It depends. I mean, if they have good follow-up from a primary care doctor, I personally, and this is just me personally, other physicians practice a little differently, I usually don't put people on long-term medications or change long-term medications too much from the emergency department because I've just met that person for like literally 60 seconds and then that's not enough time to develop a history or figure out what's going on. So if they have good close follow-up, I won't send them home with it. I'll treat them acutely here because if they're asymptomatic, it's not going to be a big deal because you're not going to drop dead from asymptomatic hypertension. You eventually need to go to a primary care doctor to get all that stuff figured out, and that's why I let them do all that stuff. If they don't and they're unreliable or anything like that, then I can send them home with some PRN Clonidine they can take if it goes up, or sometimes start them on some ACTZ or Lisinopril or things like that. But then again, those are some tricky medications that have a lot of side effects that I don't necessarily want to start anything if I can't follow back up with them. I'll never see them again. So I typically don't like it, but some people do. Yes, ma'am.
How common is the use of nifedipine? 'Cause
Never seen it done before, but it was in the literature as far as what I looked at for different medicines. Clonidine and nitro are the ones that I've seen the most, and clonidine being the predominant one for asymptomatic control in the emergency department for oral medications. But oral nitrates will do it as well. But pheoclonidine is a good medicine for emergency departments, not for long term. All right, so now we get into symptomatic hypertension, which I can kind of breeze through this a little bit easier because you guys have already had the pharmacology behind it. I don't necessarily need to do it. But this is where you get into parenteral drugs, the IVs, formulations and things like that. So yeah, in here we're just going to review in general medication use, but we really don't have to do it that much because you guys have already had that. So nitrates, nitroprusside, nitroglycerin, those are good medicines to use. You know, different medications are good for, and I don't know if I put the table, I didn't put it in your name. There's a really good table that has kind of your general medications used for specific disease process. So if you have hypertensive crisis from an aortic dissection, it's going to be a little bit different medication you're going to use for other ones. And IV nitros. Nitro is great. It very fast acting and has a very short half-life. So if you start to drop people's pressure down too much, just turn it off or lower the infusion rate, and it kind of turns itself off. Calcium channel blockers, nifedipine, cardine, IV cardine is a good medication, and IV drip. Is titrated, has a little bit longer half-life than nitro does, but its safety and side effect profile is, I think, better. As far as hypertensive crisis and things like that, this would be my go-to medicine that I would start somebody on a drip with, would be cardine. The only thing, it's an IV infusion, you can't do push doses of it. I don't like to usually start people on drips, because if you start somebody on a drip, an IV infusion, you're almost guaranteeing that person a trip to the ICU. A lot of, in the hospital, floors won't do titratable drips. Some step-down or intermediate care units will on select basis, but I typically don't like to use IV infusions for hypertensive urgency crisis unless I have to, because all of a sudden you're buying that patient a trip to the ICU, and ICU beds are in short supply. You don't want to put somebody in the ICU and take up a bed that doesn't necessarily need to be. So my go-to thing is labetalol. I really like that. For somebody who doesn't have COPD or asthma or some kind of weird reaction to a beta blocker, that, I don't know what this is supposed to say, antagonist, but anyway, so this is supposed to say antagonist, not agonist. The labetalol is a combined alpha and beta agonist. You guys talked about this already. Good, so you don't need me to go over it. This is my good one because it can be given in push dose or IV infusion. So you can give push doses, meaning you can just give doses IV, but you don't have to start a drip. And so you can give them push doses and get their blood pressure down and still be able to send these people home, versus when you start an IV infusion, you're guaranteed a hospital stay and a hospital stay in the nursing home. Esmolol is a more cardioselective beta blocker. Esmolol is a good one for aortic dissection. They use that a lot. Other agents, hydralazine. I've seen a lot of people do hydralazine, and I've given it too. A lot of the research says that it's not a very good medicine. Before, I don't know your pharmacology people told you, it's not the best medicine to give for hypertensive crisis in the emergency department. It's really great for pregnant women. It's my go-to one for preeclampsia and eclampsia. You guys talk more about that OB/GYN. But it can be given in push doses as well. It's a less reliable hypotensive profile. I think that means that causing hypotension and the time people can go into hypotension is less reliable than, say, cardine or nitro, because you just turn those medicines off, and in a specific amount of time, you'll know that it's out of their system. And IV ACE inhibitors, I've never in my life heard or seen that given, but it's in the literature. So